I'd like to thank the organizers and Phil for inviting me to participate in this symposium. I'm going to talk to you about traumatic vitreous hemorrhage. Let us define the vitreous hemorrhage. Let's go to the basics. It's an extravasated blood within the space which is outlined by the internal limiting membrane posteriorly and laterally, and a non-pigmented epithelium of the ciliary body laterally, and the lens zonular fibers and the posterior lens capsule anteriorly. This is the diagram which is exhibiting the vitreous hemorrhage, and also some of the areas like focus canal and the lens behind the lens and the subhyaloid hemorrhage are also considered as a vitreous hemorrhage. Clinically, we see these patients as a immediate visual loss, visual haze, floaters, smoke signals, photophobia, perception of shadows, and spider webs. Now, in the experimental studies, it's been known that 12.5 microliters of blood in aphakic patients and 10 cubic liters in phakic patients can reduce the vision to hand motions. The trauma is the leading cause of vitreous hemorrhage in individuals below the age of 30, and of course I've outlined the other causes. Make note of spontaneous incidence of a vitreous hemorrhage is about 7 per 100,000, and of course the other leading causes being the proliferative diabetic retinopathy and the posterior vitreous detachment and the retinal neovascularization from various diseases. Well, how do we study vitreous hemorrhage? There has not been a good animal model to study a vitreous hemorrhage, especially from the trauma. So, Yan, Ahmed, and Han in the current eye research published an article in which they used force percussion injury amongst the New Zealand rabbits. They had a control of normal eyes, and they produced a percussion injury, and they performed, of course, the usual complete ocular examination, and the criteria was to just produce a vitreous hemorrhage without causing retinal detachment. And of course they conducted a regular ocular examination in these rabbits. Here is a looks like this also advances it. Here is the photograph of before the percussion injury, and down below you see the rabbit eye immediately with a pointer. And here you see the rabbits before the percussion injury. You can clearly see the fundus. Here is immediately after the force percussion, producing a 100% vitreous hemorrhage. And of course they had a control. What were their observations? Well, here is the observation. Vitreous hemorrhage in an animal model begins to absorb in about 1 week, and about 90% of the hemorrhage is absorbed within 2 months without any intervention. Here is a sequential B scan showing the rabbit B scan without a vitreous hemorrhage and the presence of a vitreous hemorrhage, and of course within 2 months the absorption of the vitreous hemorrhage. Here are the late sequential photos indicating the streaks of blood in the beginning, and of course in the end, right here, the absorption of the vitreous hemorrhage. Here is again the picture just after the forced percussion and 2 months after the gradual absorption of the vitreous hemorrhage. What were their observations? Well, there was a gradual decrease in the blood, and they also discovered that the presence of blood indicated there were some exudates in the anterior chamber, and of course with the injury 5% of the rabbits developed a traumatic cataract. It's a severe complication after the ocular trauma. Loss and ocular atrophy without treatment will eventually, the person's vision. We had studied the vitreous hemorrhage by injecting a blood into the vitreous cavity. However, it does not stimulate the clinical situations. The mechanism, of course, in a trauma is the tearing of blood vessels by a break in the retinal vessels or a detachment of a posterior vitreous. But of course, the etiology will depend upon the various diseases, such as in retinal ischemia, there is a release of vascular endothelial growth factor, VEGF, and insulin-like growth factor. What is the pathology of a vitreous hemorrhage? Well, as I mentioned, it's an extravasation of a blood into the vitreous cavity. How does it differ from a hemorrhage in another tissue? Well, a normal hemorrhagic response would be a pigmented response followed by macrophages, phagocytosis, granulation tissue, and a formation of scar. Vitreous hemorrhage differs from such kind of a hemorrhage. In the vitreous, it forms a rapid clot. It appears as a red mass with the sharp borders. And of course, the vitreous collagen facilitates the platelet aggregation, and the diffusion of RBCs is inhibited because of the lattice of vitreous collagen with the large hyaluronic acid molecules. The intact erythrocytes exit via trabecular meshwork, and the lysis of fibrin is very, very slow. Some of the erythrocytes do undergo hemolysis, but some of the red blood cells can remain in the vitreous alive for several months. Immediately after the hemorrhage, there is a vitreous liquefaction. Iron, Fe3 as well as the Fe2 are the etiological agents. Now, it has been shown experimentally that 25 micrograms of elemental iron, which corresponds to 0.05 ml of blood, can lead to iron deposition. Of course, the iron leads to acid depolymerization, and it can cause toxicity mainly to the neural cells, RPA cells, and the neural cells, leading into siderosis. What is the natural history of a traumatic vitreous hemorrhage? Well, blood is a very slow process. Time constant is about 1% per day. Hemorrhage outside the vitreous absorbs more rapidly. The clotted blood can remain suspended for several months. Sometimes the red blood cells, along with the vitreous collagen, represent as a yellow membrane. What are the modes of evaluation? 1 minute? Okay. Well, the A and the B scan will give us the vitreoretinal relationship, and if we need to do a CT scan and an MR to determine the etiology of a vitreous hemorrhage. These are the various photographs of a retrolenticule as well as subhyaloid hemorrhage, which is also considered a vitreous hemorrhage. This is a typical B scan of a recent vitreous hemorrhage. And of course, in a ruptured globe, you need to know where the rupture is with a B scan. There is a typical B scan photograph indicating a retinal detachment. And several examples of a traumatic vitreous hemorrhage and a penetrating injury, intraocular foreign body, and of course a CT scan indicating a vitreous hemorrhage and a presence of a intraocular foreign body. So other example of intraocular foreign body, and here is a foreign body behind the globe. Traumatic macular hole as a result of a trauma, commercial retina as a result of trauma, optic avulsion, choroidal rupture, and purchase retinopathy, all examples of a recently we have noticed in the United States the glove injuries from gunshot wounds, including you heard of Representative B. Gifford with severe neurological and ophthalmic trauma. In U.S., there were 31,000 injuries from gunshot wounds last year. Of course, in summary, it is the leading cause of hemorrhage in people under the age of 30. The incidence of spontaneous vitreous hemorrhage is 700,000, and it differs from hemorrhage from the other tissues. The management depends on biology. Multiple factors predict the outcome of the hemorrhage. Intraocular body size, shape, weight, present vision of less than 200 carries a bad prognosis. Of course, the location, juvenile prolapse, large wound site, post-op retinal detachment, endophthalmitis, and the density of vitreous hemorrhage determines the prognosis. What are the factors associated with the good prognosis in a hemorrhage? Normal lens and iris presentation and normal anterior segment anatomy. The timing of surgery, of course, vitreous hemorrhage will depend upon a case-by-case basis. In the future direction, pharmacological vitreolysis to prevent PVR. Thank you.